Hi, welcome back. I'm Dr. Mark Skeen from the Department of Neurology at Duke University Medical Center. This is another in a series of videos hoping to help educate and communicate about multiple sclerosis. So the current video is I want to talk about the treatment of relapsing-remitting multiple sclerosis. And what I'm going to do, I think, for this video is talk in general terms about things that have a bearing on how we decide how to treat multiple sclerosis. There are many, many different treatments now, and it's challenging to decide which might be best. So I want to talk about the information that educates or informs us about those therapies, and then I'll probably do a separate video about the medications themselves. But this one is sort of a philosophic discussion about the treatment of multiple sclerosis. What I want to say before we get going is that I'm going to give you a lot of my personal opinion, and that's my opinion, not somebody else's, so don't blame somebody else for it. I also want to say that I can't give you good advice about what you should do if you have multiple sclerosis. Only the providers and the physicians that are seeing you and know your story and know your multiple sclerosis can give you good advice. So take what I have to say with a grain of salt or for whatever value you find in it, but discuss your therapy with the folks that are taking care of you. I'd also put in the disclaimer that anytime we talk about therapy, that I do work with sometimes the pharmaceutical companies, either giving them advice, doing research, doing non-promotional educational presentations. So if that influences what value you find in what I say, that's fine. It's up to you. So now I'm making this video at the end of October 2017. And I would say that in the treatment of multiple sclerosis, there are probably two different philosophies at the moment. And you could label them as an escalation approach versus an induction approach. And those terms are sort of useful, but not particularly, but at least they help sort of draw the line, and I want to describe that more to you. In years past, we often started out with the perhaps least effective, which also tended to be the safest of the medicines, and would put all the patients on those medicines and then escalate to more efficacious medicines only if the disease remained active in ways that we could measure, the MRI and relapses, etc. As we develop more and more powerful medicines or more effective therapies, many of us have felt like perhaps that was not the best approach. And part of what I'm going to tell you today is why we think that. Although we don't know what the best approach is. We don't have long-term trials that have compared these therapies, although some of those trials are beginning as we speak. But I want to tell you why we look at that. So I mentioned induction versus escalation. So we at Duke, for the most part, are very in favor of induction kinds of therapies rather than escalation. And I'm going to tell you why we think that's the best approach, even though we're not sure. We're not the only ones. So many, many MS experts are using or reaching out for the most highly effective medicines first, rather than this slow escalation in efficacy. And everything is a trade-off. Everything has risk. Taking no action has tremendous risk. Taking modest action in very active disease, I believe, has tremendous risk. So it's all risk versus benefit. It's also the risk of this versus the risk of that, and the risk of the medications, which is, I would say, low but present, versus the risk of MS, which I would say in general is very high. So all of these are things that factor into how we make decisions. What I would say is that, again, what follows momentarily is a lot of opinion. We talk about MS as being a relapsing and remitting disease. I think for many reasons that's okay as a superficial view, but it's not actually the truth. I personally view MS as an always active disease. I think there are things going on under the surface, and we actually know that some of this is true. That there are things that are going on in the brain, damage and repair, that's going on that has to do with demyelination, but also the axons or the nerve cells themselves. Even when we don't see it on MRI, and even though we don't feel new symptoms, and even in the areas of the brain that are not where the lesions are that we see. So I believe that MS is an always active disease, whether we can measure it or not. And that the measurements we make, the assessment of relapses and the assessment of MRI changes, are sort of the tip of the iceberg. And that makes me concerned that if we don't see relapses and we don't see new changes on the MRI, that's a good thing, but it makes me concerned that it may not be indicative of complete control of the disease. So we believe that the MRI that we commonly use in clinical practice doesn't show us all the damage that's ongoing. So just like I mentioned that we can believe there's damage even when there's not relapses, we also believe there can be damage ongoing when we don't see it on the MRI scan. The other concern is that even in those patients that we've been treating with relapsing-remitting MS for years, and maybe we've used a disease-modifying therapy that appeared to work well for them. In other words, we didn't see a lot of relapses, and we didn't see a lot of new MRI changes. Many of those people still go on to develop secondary progressive multiple sclerosis. In other words, eventually they're declining, even though it appeared that we had their disease under pretty good control clinically. It makes us, once again, concerned that the appearance of control may not be the same as having adequate control. The other thing that influences our decision making is that with all the research that's been done with all the different MS therapies, there's very little doubt that the medicines are most effective the earlier we use them. That's true of pretty much every medicine we've studied. When we look at the effectiveness of the medicine in MS, it has, let's say, X amount of effectiveness. If we look at its effectiveness very early in MS, it's much more effective. And when we look at its effectiveness late in MS, perhaps when people are evolving into a progressive form, it's much harder to show that the medicines are effective. So given that the tools that we have are most effective early on, many of us don't think we should wait to use the more potent ones till later in the disease where they're less potent, is one way of putting it. The other thing that I would say that influences my view of how we should treat MS is that, I need to say this carefully, but I think all of our medicines are profoundly safer than multiple sclerosis. So it's not that we should be cavalier about potential trouble, but the truth is the risk that's associated with our MS therapies is real but small. That doesn't make light of it, it's a statement of fact. And we'll cover some of those risks and some of those issues in later videos. But if we look at the average person with MS and the likelihood that they're going to go on to develop disabling conditions or symptoms that preclude their ability to perform their job or function in social circumstances or interact with their family and their spouse, that risk is very high for the average person with MS. MS is usually not a lethal disease, but it can be a devastatingly disabling condition. And I think if we look at the average effect of the medicine and the average effect of the absence of medicine, and I think it's true of all of our medicines, there's no question that the disease is much more dangerous than the medications are. So we need to be careful about how we choose the medicines, and we'll talk more about that in the future. But the fear of using these medicines, I think, has caused us to avoid being as efficacious as we can in limiting the multiple sclerosis, and I think that's a shame. And so it's these types of thoughts that influence our approach. So our approach is generally, at least in my words, is if I had relapsing-remitting MS, I would want to use one of the most highly effective medicines there are from the very beginning. I would want to pick whatever drug I think is highly efficacious and use it from the word go, as long as I could do so safely and tolerably. And those are issues we'll address in future lectures. But the point is that avoiding high efficacy therapy for fear of those therapy is forgetting what the danger or the risk of not using high efficacy therapy, I would say. So not everybody agrees with me. Doesn't mean I'm right or wrong. Be a weird world if everybody agreed with me. But those are some of my thoughts about how we choose MS therapies. And they're not novel thoughts. So there's a lot of MS experts around the country and around the world that would tell you similar things and would take similar approaches. So I hope it's been helpful. Discuss the issues that you find important with your physician and provider and MS experts and MS care partners. And I wish you all the best in making your decisions about therapy. Thank you.